seconds. And I'm going to give you exact 15 seconds. I'm going to start. Be quiet, or you're going to. I'm going to give you exactly 120 seconds to come up with a name for your group, a name for your tribe. Ready?
That's not on me.
Go.
What's a five?
North Carolina, we're in North Carolina. Windsor, North Carolina, Australia.
Pressure's on. You gotta make it good.
I was like shivering. I was real living color, right? Yeah.
All right, you've got exactly 60 more seconds. Yeah. You sure it's going to be competitive?
It's the name for
It's going to get you a brand. It's going to get you a 10? Are you sure? Positive. I'm going to get you a 10? You got all these other teams. How are you going to continue to absolutely with your name.
That's my team. Are you confident?
30 seconds. 30 seconds.
Hope so. Have to win the review or something.
20 seconds. Up. 15. 10. 5. 4. 3. 2. Push the submit button. You're done. It's gone. You can't pull it back. It's all gone. Okay. What's the name of your tribe?
Blue Contigo.
Now, you gotta say it loud and proud and
The
strong.
Blue Contigo!
The Blue Contigo!
Pentagram.
Pentagram. Wow. You gotta say it loud and proud.
Pentagram.
Yeah! Come on, give it to me.
We're the big kids table.
Loud, come on.
We're the big kids table.
Woo! Do you have two or one over here?
We have two. I'm
You're straddling.
I'm taking on two chairs.
Gotcha.
Team Ego?
Team Ego, as in EGO, Ego. Oh, EGO. Got it. I got it. Nice.
We're strong.
Say it loud and proud.
We're strong.
Stand up. Be my yoga therapist.
We're strong.
Yeah. Come on, over here.
Oh, we're the jet setters.
Woo! You jet setters.
Jet setters.
Where are we jet setting to?
Look.
How about
Success.
To success, I like it. I thought you were going to take us all to the Greek islands.
No, we can.
Okay, we are the Simone Biles because she is exceptionally resilient, and we feel like we should also win this contest right now. We made it into a competition because not only is it relevant, but also the resiliency is steeped into something that you talked about earlier, so we're also making a connection to points previously made.
This is your thinker. For those of you that want your pensive thinkers on your team,
So we are
this is your team.
Simone Biles,
Except now it's competition.
exceptionally resilient.
Woo! Got it. The last group.
So since this is a competition now,
Yeah, bring it, Jeff.
we are Team WAC because we're not WAC. We're from Windsor, North Carolina, Australia, and Canada.
I love that. I love that.
Listen, you didn't steep it in points previously made. And I don't know if you know, but that was part part of that, we self-selected that criteria.
You made your own
You
rules.
can't just make up rules.
Yes, you can. Because when you create new knowledge, you make up new rules about the way the world works, in case you didn't know that. Okay?
How many of you would agree that?
So, here's the thing. This is it. I love the competitive nature coming out, right? I love the names that you came up with and the reasoning and the whys behind your names. But I'm going to tell you there's more, so you have a tribe. There's lots of layers in this for those of you that love all the, you know, getting in all the multidimensionality of it. Lots of parts of this. But, are you having fun yet?
Yeah.
If you're not having fun when you're working on grants, you're in trouble. All right? So always keep it light and keep it fun. This is, again, secret sauce. I can give you all the recipes, but the secret sauce, right? You wonder why your grandmother's apple pie or whatever special dish it was that she used to make in the kitchen tastes so good. And I remember when I first started learning to make all these pies and cakes and dishes that all my grandmothers and aunts made growing up. And I would come in there and I'd whip it up and I would do everything, throw it in the oven, come out, and I'm like, shoot, my pie just, it doesn't look like hers, it doesn't taste like hers. I did every single thing. And then you know what characteristically changed one day as I got older? I walked into the kitchen and I thought, I want to bake this pound cake that my Aunt Mamie used to bake. She didn't have a mixer. She had to whip that thing by hand 300 times from 6 a.m. in the morning. Every time she walked by it, she'd pick it up with that wooden spoon. 300 whips. 1, 2, 3, 4, 300 times. She had a very strong arm. And she put that cake into the oven before we'd sit down to dinner in a wood-burning stove to cook it. And we would be salivating over that thing by the time it came out after dinner, right? Everybody was just waiting with bated breath for that. When I slowed down, and it wasn't about getting here, do this, do that, and there's some magic that happens and I don't know what it is, don't ask me to explain it. But those of you that are bakers, you will understand exactly what I mean, okay? Now, I'm gonna bake that pound cake, bake those chocolate chess pies, I walk into the kitchen, I get my coffee, I check the temperature, I put on my yoga music, I look at the lighting, I'm like, yeah, this feels good, I'm ready to bake. I do the same thing every time I write a grant, right? I get my coffee, I have my grant writing pants. You have your grant writing pants, I have my grant writing pants. And it is not these pants or these shoes. Okay? So, you want to feel good about it. The other part is now you've had a big tribe, you've learned about each other, you got a little tribe here. I'm going to give you all kinds of opportunities to check out different people because meeting these people are really important, and this is your support network. You're all right here on this campus. And somebody said something earlier about wanting to have something where you get together and you're just supporting each other. And I know I'm here because of the Women's Health Center, and I am just throwing out there that I'm going to ask this question, right? How many of you would love the opportunity as being sponsored through the center just to have a chance just to get together sometimes and check in with each other and see how life is going and have some encouragement on what you're trying to work on? Would that be cool? Mm-hmm. I want to know. Let me see. Yeah. Okay. So there's some ideas. And I would say to you, even if you're not a women's health researcher, still come to some of those events. Because, A, you never know. What they're working on might be contagious. You might get really interested in it. You might have something to offer that you don't even know you have to offer. But more importantly, you have some friends and some colleagues to support you. The other part is, why did I ask you to ask a name? Create a name.
Gives us an identity, or?
It gives you an identity. And more than an identity of your team, it's going to give your grant or your project or your intervention an identity. It's no mistake that my XCAP intervention is copyrighted, patented, and trademarked. YOCAS, for my yoga intervention, is copyrighted, patented, and trademarked. It is my name, my brand, my study name, my study brand. People know it. When you say the Yocas intervention and I'm standing up at a 35,000 person conference with people from all over the world for cancer, you see Yocas, it doesn't matter if it's one of my mentees or not, they're like, that's Karen Mushton. When you see XCAP, people are like, that's Karen Mushton. That's University of Rochester. That's URCC NCORE. That's cancer. That changed a lot of things. Oh, that's written in the guidelines for treatment for cancer patients. So branding is important. And I would encourage you to sit down and start off by thinking about a cool, fun acronym or name to brand your study or your trial. So now I have Yocas 1, Yocas 2, Yocas 3 we're working on already. We're going to already have Yocas 4 in the plan, I got work to do until I turn 80. When I think about it. But yeah, we have all these like iterations of what we're doing with the studies and the follow-ons, okay? And then I have different branches of it too. So I am creating versions of it that will work for more diverse samples. Sometimes I'm learning I have to target manuals, and if I'm working with men with prostate cancer, only create the manual only for men. If I'm working with only women, for women. If I'm working with true African American individuals with African American ancestry, I need to create the manuals and the notes and everything that work with that. I'm translating stuff into Spanish. It's not going to work if I translate it into Spanish and everybody in that manual looks like me. Right? They need to look Hispanic, so they need to see people. You know, this is the stuff you learn in terms of behavior change, social modeling, all that kind of stuff that you see. And here's the cool part, I use all my cancer patients and all my stakeholders that are from all around, and I bring them in and they actually help me design the manuals. So when you wonder about how I spend all these hours getting all this done, I don't. I bring in a group of people who know the population and they do it. They help me. They told me how to make the videos. They told me that these 3 ways that you filmed it, Karen, they don't work. Now you need to pay that guy to come back and you need to refilm it. Here's how you need to do it. Right? And I do what they tell me. So branding, marketing, making sure not just what you write in your grant, but because sooner or later you're going to have your recruitment materials and all that stuff. All that stuff needs to be branded to your study and marketed to your clinical trial and your population, community, all of that. And that starts in the writing of the grant. For those of you who think, you know, okay, I got a cool name, but I'm not going to worry about how to design my pictures for my intervention or this or that or videos or whatever I'm doing. I'll do that after I get the grant. You just made one of the biggest colossal mistakes you'll ever make. Because you need to know what that intervention is, exactly what you're going to do with it, exactly how you're going to implement it, exactly how it's going to play in Peoria with the people that you want it to play with, before you ever submit that grant. Because the worst, first of all, it will come through to a reviewer that you do not know what you are doing. You cannot articulate it well enough, and you can't articulate the fine little details that need to be articulated for them to believe that you know what you're doing. Right? So you got to brand it, you got to put all these details all the way down to the pictures and various things like that. You want to understand all of that together. So that's one of the reasons why I wanted you to come up with a brand and a name. Okay? It's one of the very first things that you need to do when you're preparing to design a clinical trial, no matter what grant mechanism you're going for. Okay? Think about your study, brand it, brand your intervention. Right? And that doesn't matter if you're making a functional food bar, or you're doing a weightlifting program, or meditation, it doesn't matter. Okay, brand it. Make it your own. Alright. So, the next thing that I do in terms of thinking about designing a clinical trial, and this next piece is complicated. We teach courses that are an entire semester long over this. So the next thing I do is I actually sit down and I figure out, okay, I'm going to do a randomized clinical trial, but is it a phase 1, a phase 2, or a phase 3? What am I going to design? Do you guys even know the terms phase 1, phase 2, phase 3? No. Not a lot of people do. Many people who come join my faculty don't know what it is. What do you think that is?
As a research administrator, I'm actually studying this right now. So phase 1 is where you have a very small group of people and you begin to study the safety of the intervention and like the size of the intervention. So maybe, 20 to 40 people, right? Then phase 2 is a larger group of people where you kind of continue to study the efficacy and maybe tweak the dosage. And then phase 3 is where it's a much larger group. Phase 4 is when it's in public kind of domain and it's being tested. And sometimes you'll see drugs that'll be pulled after it's in public because suddenly we'll figure out that there might be some adverse effects. You might have heart issues after taking this drug for pain months later. That's kind of a very...
You did a really good job of that.
Okay, good. I might pass my exam.
Phases are hard, so we would love them to be like distinct. Phase 1, phase 2, phase 3, phase 4. So there are some guiding rules of thumb, but still people will debate back and forth. This is phase 1, phase 2. And so the first thing I want you to think of is, where's your body of knowledge? Are you testing, is there a need to test, or are you testing some kind of intervention that we don't understand the safety of it? And you hit the importance of phase 1's, right, the nail right on the head, okay? Phase 1's are about safety, but not in the way that you might typically think of safety, okay? It is about taking your intervention. These are usually not randomized, and they're usually tiny, like 10, 12, 15. This is a study where you want to do it with as few people as possible. It's exactly the opposite. There's no power calculations or anything like that you have to think of statistically, all right? What you're going to do is you're going to come in and you're going to say, all right, here's the intervention I want to give somebody. So in my case, it's an exercise intervention. I'm going to give them this exercise prescription. I'm going to ask them to do it, and I'm just going to look at, A, were they able to complete it, finish it, do what I asked. B, if they did what I asked, what does their toxicity profile look like? Okay? Did they come away with tachycardia? Did they bruise an ankle? Did they have, those of you who are very familiar with muscle soreness and concentric and eccentric contractions, did I create some really high level of inappropriate muscle soreness in this group or this population, especially if it's a chronically ill population? And if you're okay at that dose, and those 3 people did fine, then you bring in 3 more people, you up the dose, they get the next high level, okay? And here's the kicker about that trial. You go until you get a toxicity. You go until you see a toxicity that is unacceptable. So you do 3, you up the dose, you do 3, you up the dose, you do 3. Now, what does that mean? Because in the context of a cancer patient, am I going to go until I have a death? No. Okay, we're not going to do that either with pharmaceuticals, this is the way the FDA does some of their work in phase 1s too. No, but you're going to go until you start to see things that you deem are inappropriate toxicities that you don't want to elicit in your patient population. All right. So for a food item, it might be something like bloating or distension, or maybe you create a diarrhea or things like that. For an exercise intervention, it's excessive muscle soreness, excessive tiredness, things that you literally didn't kill them, hopefully, right? But, or maybe they did it and what happens is their heart rate became so elevated that they're not able to recover in a decent amount of time. So you're putting them at some increased cardiac risk that you don't want to put them at in the process of what you're doing, okay? And so then what you do when you hit that level, what you want to do is back off to the level below it. This is generally how we tend to do it. Sometimes now people will come down more than one level, but this helps you find out what is the max, what we call the maximum tolerable dose, all right? And then the other thing that sometimes you can do in a phase 1, and some people say no, you shouldn't do it at all, but money is scarce and clinical trials are expensive. So when we do them where I am, I also still give them questionnaires or assessments on the primary outcome that I'm interested in. So I will do the dose, look for the toxicities, did this move the needle on the thing I'm interested in it moving?
Did you also think about that as the lowest effective dose?
Yeah, so that's what I'm getting at. So then I go up to the next dose, look at tolerability, and look at effect. Look at tolerability, look at effect. So when I'm backing back down, it's a double-edged sword in the way I make the decision. I want to come down enough that I don't have toxicities, but I want to stay high enough that I have what we call the minimally effective dose. Because don't forget, that first dose I gave you might not have done anything for the thing that I'm trying to fix.
So how do you write that in the grant? Like if you don't know exactly how high you're going to have to go, or do you have to estimate that prior to putting the grant in? Where they don't think you're fishing, so to speak.
So what we did, so you got to remember a couple things, all right? A grant is a grant, right? So you don't have to do exactly what you say. It's not a contract like it is with the Department of Defense. So what we do is based on the literature, based on what we know about either the supplement or the exercise or whatever it is. We've done these in RO3s, by the way. We've done the phase 1s with RO3s. And based on the literature, we say what we think the known maximum doses in the literature, and then we talk about what the effect sizes we see in the literature, and we make the case for, do we go to, you know, if we have that, then we don't need to do a phase 1. You're going to move on to something else, not a phase 1. But if you think that part of the problem where you're not getting the effect that you want is you need to go higher, then you need to do more work establishing the actual dose, then we make the case for going higher, and we will write in, we're going to go to this, based on general exercise prescription principles, and that one based, you know, and here's what we expect. But in the end, when you're running your study, if you need to go another group higher because you didn't hit toxicities, you go another group higher, right? And let's say you run this and you're up now at like 21 people, right? So you've done 7 different levels. You're getting to a lot of levels. And so then the question becomes, do we have to go to like a crazy toxicity? Are we seeing an effect size that's working at this extra levels, okay? And the other part I'll tell you about eating and exercise and things like that is that people often say, well, this is fairly innocuous, right? I mean, we can give somebody a curcumin supplement. We eat curcumin in our food. It's not really going to hurt anybody, right? Well, that's not true. You take a cancer patient, for example, who's undergoing chemotherapy, and you blow a bunch of curcumin into them through a bunch of pills, and the next thing you know, their whole digestive tract is burning, and they're having a reaction, and you've just compounded the oral mucositis that they have, the metal mouth that they have, they already have a problem eating, and you just screwed it up royally, right? So that's why these kinds of things of really understanding the toxicities are important. And those of you who aren't working with chronic populations, you're working with like elite athletes and stuff like that, try giving an elite athlete indigestion or heartburn before they go to the most important competition of their life. They're never going to want to talk to you again after that, right? So there's the side effects profiles and toxicities that you have to think about are important. So that's a phase 1. So minimally effective, maximally tolerable, lots of safety measures and stuff that you look at on there. Phase 2 is where you start to look at what we call efficacy, so the first true signs of efficacy. This is where you bring in a control arm, where you really want to be, you know, there's lots of ways to think about a control arm. You want to have your intervention now, you've decided your dose, this is what we're going with. If you're doing this for the first time, I'm going to tell you don't make the mistake of having 2 or 3 or 4 arms. Don't do that to yourself. Have the clean trial. Okay, this is what we love to see. This is the bread and butter in the world of clinical trials. The intervention versus either standard of care or a control condition, or like a behavioral or a placebo condition. So you don't have to have a placebo in a standard of care. So when I did my first yoga study, nobody was doing yoga with cancer patients. So my comparison was yoga versus standard care for people transitioning off treatment, which meant nothing. It meant I just give them the measures, they talk to their doctors, they do the follow-ups the same way they always have. What we call standard care or usual care. Those terms are sometimes debated, right? So one thinks usual care, so the key of usual versus standard is oftentimes usual care is what a practice might do. Standard of care indicates that they're adhering to some sort of treatment guidelines out there, medical treatment guidelines, and that the patients are at least receiving the minimal standard of care that we'd be expected for a cancer patient in that context. Which doesn't mean anything for the indication. When I started this to get standard treatments for symptoms and side effects and toxicities, especially once you were done with treatment, nobody was doing that. You were ringing the bell and walking out the door and saying, good luck, I'll see you in 3 months, right? Nobody was saying, oh, by the way, I want you to go over here and do yoga for your fatigue and your pain and, you know, all these things. So in a phase 2, you want your intervention versus whatever that control arm is going to be. So it can be a usual care, it can be a standard care. And if there isn't, you don't have to do a behavioral placebo or a placebo at that point in time. And one of the reasons why you may or may not choose to do an active placebo at that point, and you have to say all this in your grant, this is not a given, you have to lay all this out, is because you may not yet understand why your intervention works. And if you don't at least have a really, really good educated hypothesis on why your intervention works, then you better be careful about designing any kind of placebo condition, whether it's a placebo drug or whether it is a placebo behavior. Doesn't matter. Or a placebo food item. They're all the same, okay? You better make sure that you don't accidentally have some kind of ingredient in your placebo condition that is super active, that's going to actually be stronger and better than the thing that you believe is going to work. And the only way that you're going to have that is to have a lot of knowledge about why your intervention works or why you think a really, really good, strong, lots of data to support an educated hypothesis about why it works, okay? In behavioral work, so a lot of times I hear people say, we don't know how to design a good behavioral intervention. What's a good intervention for exercise or yoga or, you know, sham acupuncture, things like that? What's a good intervention for a Mediterranean diet intervention, things like that, right? So when you think about this as a whole, all right, this is where you actually have to be willing to be a scientist. And everybody says, well, we don't want to break yoga down. We don't want to know whether it's the breathing or the meditation or the asanas or, you know, the wonderful warm fuzzy instructor you have in front of the room. It's the magic of the whole, right? That's what everybody likes to say. Well, of course it's the magic of the whole. But wouldn't it be nice to understand even how the whole pieces work together and come together to create that magic? The only way you're going to do that is start to really look fine-tuned at the different pieces. So if you're eating a Mediterranean diet, is it the excess olive oil? Is it the different kinds of meats? You know, is it the fruits and vegetables? Is it some magic in an olive that doesn't exist in the oil? That is, you know, he's eating a lot of olives. Like what? So those things become important for you to ask. You can begin to ask some of that, maybe sometimes if you have the funds in a phase 1 study that you're doing locally. You won't write that in your grant. But when you get a little extra money, could you do some work to really try to understand a little bit of that as you're doing that phase 1 in those first 20 people? Of course you can. That's what we do all the time with our junior faculty. If they get something like that funded, we try to find a little extra funding so they can do a few extra things with that trial before it's over. So they got an RO3, great, it's money, but it's not enough money to take blood and analyze blood. It's not enough money to collect stool and look at the microbiome. But that's the microbiome in 20 people. And you might say, well, you can't do anything definitive with that. I can do one thing beyond a shadow of doubt for that that's going to really play well for that grant for that phase 2 trial. I can show you that I can get the patients to give me stool, which is no small feat, And I can show you, I can collect that stool, I can get it to the lab, I can get it analyzed, and I can get all these amazing microbiome markers out of it. So, now, instead of the 150,000 I got in this R1 or R3, I want you to give me 350,000 on the on the R21 to go do what I want to do in the phase 2. Because now I want to look at this compared to another arm, I want to add stool, and look at these markers, and I'm going to do this in 80 people. Okay? So phase 2, initial efficacy, comparing your intervention to your control condition. So you calculate effect sizes within and between groups. Compare them. You're going to use that data later to do your power calculations for your phase 3. And you can begin to look at some other things, confounders, mechanisms. You can provide a little bit of that in the phase 2.
Is there different cultures within NIH in terms of how they view these phases?
There's different cultures.
Can you repeat the question? I'm sorry.
She asked me if there's different cultures within NIH as to how they view these phases.
Do you understand why I asked that question?
I will tell you that there are different cultures. Nobody will tell you perfectly the same definition. So you will read the books, and if you guys get yourself a Design of Randomized Clinical Trials book, it's no magic. They're all pretty good. You can go on Amazon, find one, buy it, right? Put it in your repertoire. At the end of the day, this is like asking, how many of you understand stages of change from behavior change? Is anybody ever really in one stage but not any of the rest? No, we know that. Clinical trials in the phase 1, 2, 3 is the same. So what happens is you'll see people that will say, well, maybe that's really, you can do a little of that phase 1, you can do a little of that phase 2. We oftentimes will design trials where we'll say this is a phase 1/2 because we mix up the outcomes where we're looking at some safety and toxicity profiles, but we're also going to have a comparison group because, let's face it, they're expensive, and once you do this and the time it takes, you want to have a maximum impact for that. So what I find is any grant you write, it's more about understanding kind of the general demarcations of safety, initial preliminary efficacy in phase 2 is where you're comparing it to something else. And then the phase 3 is, okay, Betty barred the door. You will do a power calculation. You will name your effect size. You will name that primary single one outcome that you are testing, and you will hang your hat and bet your life on that. And if you miss it, you have a null finding. You have a null trial. You're going to stand up there in front of the room of all the oncologists and say, it did not work.
I guess the reason I asked that question is, you get this, why do you do this, and why, and so, maybe what I'm hearing you say is that you need to just put it painfully in front of them. We're defining this as a phase X trial where we are testing X.
Yes, and put a reference there. So that's why you want that clinical trials book, okay? So, you do have to sometimes say to your reviewers, this is a phase 2 trial per, whomever, Joe Schmo et al., right? And put the reference there.